Welcome back to Mostly True Psychiatry with me, Dr. Mellon. This is part of our How to Treat Anxiety series. Last video was going over the generalized anxiety disorder and panic disorder, kind of using those as the two prototypical examples for all anxiety. This video is going to be talking about the general concept and treatment strategy for anxiety disorders. The next couple videos will be going over the drugs and kind of end with a capstone of like just a table I'll make. So it just shows you, here's the drug, here's the first dose kind of thing. And here's how you increase the drug specifically. So it's easy, kind of like I did with the MDD series. So treatment, we are doctors, we are pill pushers. So we're going into the pill pushing section, general information. Okay. So rules of thumb. I like them. So the general rule for treatment of anxiety, everyone gets an SSRI or SNRI. They take it every day. It's their first, second, third line treatment. If there's any uncertainty in the diagnosis of this anxiety, it's hard to go wrong with picking escitalopram, paroxetine, or venlafaxine. I'll show you why real quick. Because I'll include this table with the, based on actually looking at randomized controlled trials as well as FDA approval, escitalopram, paroxetine, and venlafaxine work for very disparate anxiety disorders, right? Panic disorder and generalized anxiety disorder and social anxiety disorders. So, in short, you don't care why it was being caused. Great choice. It can't go wrong. And if I had to pick it, I'd probably say escitalopram, little no side effects, cost isn't the best issue, so maybe that'd make it second line for some patients. They go to paroxetine, more calming. It's supposed to be a bigger, fuzzier molecule. We'll talk about later. It can hit more side effect profiles, which is why some people don't like it. And you probably haven't prescribed it much. And then venlafaxine, for me, would be second line just because I hate the withdrawal. It's hard to get people off that drug. All right, so those three. So basically, they're breathing and anxious. You should just start with an SSRI, SNRI. There's exceptions to every rule. So exception one is when it's a person who only needs PRN as needed. This is a person who has strictly situational anxiety. They got to get on the plane. They hate planes. They know they're going to die on the plane. Fine, give them propranolol, give them clonazepam or whatever. When it's purely situational, you're really just treating autonomic nervous symptom signs. They're ramping up their fight or flight. In case there's any confusion on your part of what propranolol and these drugs are doing, basically when fight or flight response, it depends on just what they pay attention to, right, and which one bothers them. So some people, they just, because it's the same response. You dump adrenaline, all the stuff kind of happens. It could be that they notice they're lightheaded, feeling dizzy, unsteady. Well, that's really because they went to tachypnea and they have shortness of breath, which is causing a paresthesia, and they're noticing it a lot, right, too. You get tingling when you blow off all your carbon dioxide. Try some deep breathing for about 10 minutes, you get the same thing. And then when you're hyperventilating, it trembling and shaking from that. So people get a fear of, like, they're gonna die, they're gonna go crazy, I'm gonna lose control. I just, feel wild. Some people it's really cardiac involvement, so palpitations, chest discomfort, that kind of thing. Some people it's like just a vasoconstriction dilation issue, so like sweating, chills, hot flushes. Some people it's just the butterflies in the tummy and they get the nausea, abdominal discomfort. And then some people just things don't seem really wrong. They're more of like the fear of dying, going crazy. They get depersonalization, derealization going on. Depersonalization, I'm not real. Derealization, nothing around me seems real. Not terribly uncommon for anxiety. So the one thing to know there and tell the patients, and if you're giving PRN for anybody later on, is that it's not magic. It's not going to take, I feel better. It's going to have like a 30-minute lag, 20, 30, 40 minutes. Can't just slam an IV with lorazepam into them to calm them down with the Haldol. So it works best if they know they're going to be anxious and they take it ahead of time, or if they are okay with the idea it's going to take 20 or 30 minutes. personality disorders. So this is gonna be a schools of thought thing more than anything else. If you go by the I don't know, the Blessed Church of the APA and the American Medical Association, these kind of groups. So like the APA guidelines state that psychiatrists should treat the symptoms that are being presented with and things like borderline personality disorder, even though all the evidence says that doesn't help work or do anything. But so you can always treat symptoms. You can see your job 99% of the time. That's what I think a lot of psychiatrists actually do. They just see themselves treating symptoms. That's how they prescribe, regardless of what they say. Actions speak louder than words. So you can treat personality disorders if it's anxiety and you think it's really due to it's the rigid thinking, it's the affective instability more from adverse childhood events or whatever. You can make them feel like it's a medical problem and a pill's going to fix everything, instead of giving them like actual dialectical behavioral therapy or actually working on things that'll help them over the long run. And if you're, awesome A+ student, you'll try to do both. But only residents do that. Nobody has enough time. Everybody does the wrong thing. It's the real world. So let's see. That gets us through that. Everybody gets an SSRI. Everybody gets an SNRI. And those two exceptions, unless it's purely situational or it's really just a personality disorder. Medications and general ways to think about it. So you've started your SSRI or SNRI that everybody gets. You can do two ways to do this. So here are kind of the ways I think about it. Person comes in and they have lots of anxiety, and then they get overwhelmed at times, and that's happening every day or 2 days or whatever. It's not necessarily panic attack, right? Panic attack. It's lasting 30 minutes, right? I mean, if you're truly trying to take a medication for panic attack, that's actually would be pointless, because it should be within minutes and it's gone, right? That's the definition. So if you eat it and it's in my stomach and it's not in my blood, it doesn't do anything that's helping. So it's really you're giving it because their anxiety gets so high they're not managing. They're very stressed out. So I think it's perfectly fine to bridge, to help people out. So at the beginning, you give them their SSRI, SNRI, and it's just they need more. They need short-term help and long-term help. And you start polypharmacy. So you start them with one of the buspirone, propranolol, Atarax, that kind of drug. Sorry, hydroxyzine, not Atarax. And that's super reasonable. What you're looking for in the evaluation when they come in is you should always give them something to sign, or you write on the scale. I have a fake Likert scale, 1 to 10. 10's awful. 1 is you're dead because you have no anxiety. Where do you fall on that, right? That kind of thing. And these real excessive episodes, when they're real extreme, how often, how frequent, how long. So knowing that you're starting a process that's going to take months probably to get them in a good place. SSRIs, SNRIs classically take up to 6 weeks to help with anxiety. Depression it's like 4 weeks. It's longer with anxiety, so it's quicker to get somebody to not be anhedonic or suicidal. From a research that I've seen, that I thought was pretty good, pretty interesting. It was a post hoc analysis, long way from gold standard, of RCT trials done, and they just saw that if you get at least a 20% reduction in symptoms within 2 weeks, 20% in 2 weeks, then it was pretty likely to work. But if it didn't get a 20% reduction in 2 weeks, like if you didn't go from your Likert 9 to 7 in 2 weeks, 80% chance the drug wasn't going to work. So I would say, which means if you have no benefit at 2 weeks, I'd switch drugs. You're wasting everybody's time. So now the patients come in. It's that second visit, and you're trying to see how they did on their little Likert scale, and you're seeing did they get a symptom reduction or not. So I would say less than 20%. I would just say treatment failure, personally, and you can go ahead and switch to another medication. Just sticking with the first line drugs. First, not switching to second or third. So SSRI to an SSRI, and then go to an SNRI, that kind of thing. If you got about a 20 or 30% reduction, and it brings them down from like a 8 to a 5, and they said they'd be good at a 3 or 4. You could consider just waiting at that point. That would be reasonable, because again, you're expecting more benefit over the next couple weeks. If they're kind of at a max tolerable dose, maybe it's sedation, side effects from the drug, or they're just at already at a high dose of that drug, and you don't really believe in giving more than 40 milligrams of citalopram, that kind of thing, then your decision is, am I almost all the way there helping them? At which point do I go ahead and add an adjunct, or do I say it's a failure and I just go ahead and switch over to a new drug? So kind of like your increase, switch, wait, add adjunct kind of decision point after the first visit. You either got basically no benefit, so you should switch drugs. You got 20%, it wasn't really much, you should probably go up. If they're kind of close to okay, then you can just wait and see if they get more benefit, and if not, on the follow-up, you can increase the dose again. But if you're at a max tolerable dose due to side effects, or you're already at the top end of the drug, and they're almost okay, probably just add an adjunct at that point. With the thought process, you'll eventually get them off the adjunct. All right, so remission, response, relapse, these kind of ideas for anxiety. So this is for your information, not the patient's. So if we're taking like generalized anxiety disorder, the response, so like a 20% reduction or something, or 50% reduction, depends on the research, it's all arbitrary. It's only about half the patients with a particular SSRI or SNRI. So you're gonna have to give them 2 drugs to help most people. To be able to cover the majority of them, you'll have given 1 or 2 drugs. Once you get them on a drug that gets a response, again, it's like half again, or even a third, that they'll go to remission. So you'll go through 2 drugs to get most people to where they're getting a response, and then you'll go through 2 drugs to get them to the remission. So that could be up to 4 drugs, depending on how that's looked at. And that'd be individual trials. So once you start to combine drugs and stuff, it's all out the window. We have no idea. And then relapse, if they're at remission, you stop. Almost half within 3 months. But this isn't as bad as it sounds, because remission is actually not the goal for anxiety treatment, like it is for major depressive disorder. Major depressive disorder, you don't want to be anxious, you don't want to be depressed anymore. With an anxiety disorder, you're just wanting things to be manageable. You're really symptomatic control. Everybody's going to be anxious to some point, and that's where they just need therapy. They need cognitive behavioral therapy or something else, so that they can learn how to cope and have resilience, and have a different viewpoint about what it is they're experiencing and what does it really mean, right? It's like, okay, my heart rate's a little higher. Does it really matter? Is anything bad gonna happen? No. When I go running or hold my breath, my heart rate goes up. So we'll leave it with that today with this video, and I'll leave you with this image just as kind of I'll put it in the notes later, so you can just download it from Google, but from a Google Doc. But again, these are all drugs that are orange means it's FDA approved. Everything else just means it has randomized controlled trials showing its efficacy. Again, if you start everybody on escitalopram, then go to paroxetine, then go to venlafaxine, you're covering anybody. And that gives you step 1, 2, 3. So, all right, I hope that was helpful. It's been me, Dr. Mellon, with Mostly True Psychiatry. Cheers.